Paso al simposio número 3, terapias de reemplazo renal en la tercera edad, en la cual vamos a tener varias discusiones acerca de los manejos, los más debatibles, pues las terapias de diálisis, las modalidades que podemos ofrecer en nuestro país y sobre todo tratando de extrapolar información fuera de nuestro país, pues sobre todo viniendo de grandes bases de datos como la estadounidense. Ver si esto es compatible con lo que nosotros vemos, ver si esto es verdaderamente un reflejo de lo que hacemos y tratar de juntar más información para poder validar estos datos. Así que vamos a dar paso a la primer ponente. Ella es la doctora Xochitl Durán.
El primer ponente es el doctor Stephen Caldwell, el cual nos va a presentar la ponencia de la edad como criterio de ingreso a la terapia renal. El doctor Stephen Caldwell viene de la Universidad de Alberta en Edmonton, en Canadá, y es médico nefrólogo, y esperemos que los puntos que toque el doctor sean de interés para la práctica clínica de cada uno de los médicos que estamos aquí. Adelante, doctor.
Thank you very much for what I can only assume was a kind introduction, as I don't speak any Spanish and I didn't have my earpiece in. So if he said anything bad about me, please tell me later. It's a great pleasure to be here in Aguascalientes. This is one of several years that I've been coming, and I'd like to thank the organizers and especially Dr. Garcia for continuing to invite us back here. It's a great pleasure to have the association that the University of Alberta has with you in the Mexican nephrology community. It's a great pleasure to be at a conference too that's presenting on kidney disease and aging, and I have the honor of presenting a bit of a topic with respect to acceptance of renal replacement therapy based on age. And I put a picture from the movie Oliver, and the quote should read, "Please sir, I want some more," because we want some more dialysis for all of our population. And I thought I'd just explore some of the barriers and challenges that might meet our aging population as they approach end-stage renal failure. So it was George Bernard Shaw who once said, "Youth is wasted on the young." And I wanted to ask the question, therefore, is dialysis wasted on the old? And that's what I want to try and present for you today. In order to start and give a bit of a background, I want to take you a continent away to South Africa and give you an example of how it cannot be a good thing to be old and seeking dialysis. In South Africa, rationing of dialysis was commonplace under the apartheid regime until very recently. People did get dialysis, but you can see the hospital on the right-hand side here is Tygerberg Hospital, an expansive hospital with great long hallways running east to west. The east side of the building were for whites only, and the west side of the building were for non-whites. And I can tell you, in the apartheid era, there were no dialysis units in the non-whites section. So with the abolishment of apartheid and the opening up of all of the activities for the entire population of South Africa, rationing still had to continue, and they had to come up with some criteria to decide who would get it and who wouldn't. So it might be to your surprise to realize that the only people who get and now get dialysis in a rationed society like South Africa are those that qualify for renal transplantation. And this is the quote from the selection criteria in South Africa. It says, "Kidney transplantation is the most cost-effective form of renal replacement therapy, promises the best quality of life and the best survival rate. Therefore, all patients accepted for renal replacement therapy must therefore be eventually suitable for transplantation. So if you're not a transplant candidate in South Africa, you will not get dialysis." Some of the criteria that they came up with, they had to come up with a way of justifying this or categorizing people. So they came up with 3 categories to put people in. The category 1 would be patients who must be accommodated, and the resources for renal replacement therapy had to be found. And you'll see how they define these categories in a moment. Category 2 patients would get dialysis, but only if resources could be found and would allow, and the waiting time that they had to wait and the potential outcomes of their individual cases on dialysis might dictate whether they got it at all. And then finally, there would be a large number of people in category 3 who would never be offered dialysis and be managed only conservatively. And you'll see what some of the criteria were for these categories. So the category 1 patients who would definitely get dialysis, the resources must be found, would have to have a BMI less than 30 and be HIV negative, or at least have their CD4 counts and their viral load well controlled. They must also be hepatitis B surface antigen negative, but the most important and the applicable criteria to what we're talking about today is they had to be less than 50 years of age. That's the cutoff age for dialysis in South Africa. For the category 2 patients, they would be much less likely to get dialysis. They would have to wait, and only if resources were available would they be offered it. And some of the things that may positively influence whether they got it would be, first of all, some social factors, like their home circumstances. Did they come from stable homes with caring and supportive families? Were they themselves motivated and had great social support? And most importantly, perhaps, did they have reliable and regular transportation to get back and forth from the dialysis unit? Some of the negative things that would impact on these category 2 patients would be medical things like having a BMI in excess of 30, having uncontrolled hypertension or left ventricular hypertrophy, viral hepatitis if they smoked or had diabetes, or had uncontrolled HIV, if they had acute renal failure without expectation of survival, and if they'd had a previous transplant that failed. All of these things would be negatively against them. But again, bringing it back to our topic today, the most important negative feature would be age over 50, would be a negative impact. And then finally, the group of patients who would never be offered dialysis would be any of those patients that for whatever reason were determined not to be a transplant candidate. And they would include patients with AIDS or uncontrolled HIV, who had problems with substance abuse or use, who were significantly overweight or hepatitis E antigen positive, any patients with a malignancy or other advanced organ failures, serious mental or behavioral abnormalities, or habitually non-compliant with their therapy. But again, most importantly, age over the age of 60 or over the age of 50 if they were diabetic, never to be offered dialysis in South Africa. So I first present South Africa really just to set the stage for how bad it can be with respect to age being a barrier to renal replacement therapy. I myself trained in a country where up until very recently there were age barriers as well. When I was a houseman at the Western General Hospital in Edinburgh, Scotland, this is the hospital that I trained in, they opened the dialysis unit there on the day that I started medical school, and unfortunately closed it on the day I graduated due to lack of funds. But for the brief time that it was open, there was a definite age limit for accessibility of 65. Nobody over the age of 65 in Scotland at that time was considered for dialysis. So you may think, having presented South Africa and then Scotland, that it's not really a problem of wonderful countries like Canada and Mexico, where we've chosen to live and chosen to practice. So maybe it's not our problem. We've known for years, for example, that it is a financial aspect. So here is the prevalence of patients receiving dialysis. Just recently, the crosses are low-income countries, the squares are middle-income countries, and the circles are high-income countries. And the inference is obvious. If you're in a high-income country, more people are on dialysis than in low-income countries. There's no denying that. It's the same with transplantation as well. The gross domestic product and number of kidney transplants per million, you can see as the country gets wealthier, so does the number of transplants go up. So again, maybe it's not a problem for Canada and Mexico. But it had to be studied to see what sort of decisions were going into whether patients would get dialysis or not, and whether age was a factor. So one of the first studies to look at this was the so-called support study, or the study to understand prognoses and preferences for outcomes and risks of treatment. And it looked at thousands of patients who were admitted to hospital and a decision process about whether life-sustaining therapy would be given to them during that hospital admission. This is a very busy slide, but what I wanted to point out to you specifically that the mean age of patients, so these are patients for whom a life-sustaining treatment indication arose during their hospitalization. And they were grouped into three categories. They were either, did they require ventilation, intubation and ventilation? Did they require a major surgery? Or did they require dialysis? And you could see in the patients under the age of 70 and over the age of 70, here are their average ages, 53 and 78. But with respect to what we're talking about today, here's the number of patients who wanted the life-extending care. So it's an important first step to establish in a decision-making process whether the patient themselves actually want these things. But you can see in the younger patients, half of them definitely wanted these life-sustaining therapies. But even in the older patient group, at least a third or more did want life-sustaining therapy. So here's what we're talking about, as I mentioned: ventilatory support, major surgery, or dialysis. And what you can see from this slide is in the older population, over the age of 70, you were still very likely to get your major surgery as you would be if you were younger, but as you got older, much less likely to be offered intubation and ventilation, much less likely to be offered dialysis once you get to the age of 70, and certainly very unlikely to get it if you're over the age of 80 while hospitalized. Here's the same data presented in an odds ratio, and again I'll highlight our age group. So in the over 70s and over 80s in dialysis, a twofold less likelihood to be offered dialysis when in hospital and sustaining a life-threatening injury. So you can see if you're under the age of 50 as a reference, 50 to 59, pretty much the same. Slightly less if you're approaching 70, but once you get into the 70s and 80s, much less likely to be offered dialysis for life-sustaining therapy. Here it is graphically represented, and it sort of summarizes those tables that I've just shown you. Everybody gets their major surgery, and age to surgeons doesn't seem to be a barrier. And those of us who either know surgeons or perhaps are surgeons probably aren't surprised by that statistic. They'll operate just about on anybody. But dialysis and ventilatory support seem to go in parallel with respect to increasing age and the less likelihood of being offered it. What might be more important, though, again from a bit of a busy slide, would be to look at some of the mental and some of the social things that go into the decision making. So again, we're looking at patients getting older, but I point out first, this is what the patient wants. Does the patient want these life-extending care things like dialysis? And as you can see, as they get older, maybe if you average the 70s and over 80s, maybe a third of patients definitely still want to be considered for these life-sustaining therapies. But if you look over here, what does the physician think? The physician thinks that they would definitely not want them. So a third of them want it, but doctors think very many less of those patients would want it. And then if you ask the doctor himself, would he want it or she want it if they were in the same position, they say absolutely not. And then the most revealing statistic is probably this last box. For patients who do want the life-sustaining therapy like dialysis, the doctor thinks that they don't. 80%. So the patient wants it, but 80% of physicians think that they don't. So there's a tremendous communications gap here. And lots of room for improvement in that communications about what people want and how they're offered and what they're offered. And these are the scare tactics that are always coming in the Western world, that funding will be cut for dialysis, and the fear being that if we cut funding and dialysis has to be reduced, who will be the ones that are reduced? And the elderly are an obvious target. So it wasn't too long ago, back in 2000, when a group of nephrologists and ethicists got together to try to come up with a plan for shared decision making about dialysis. Not just for the elderly, but specifically we'll talk about that elderly population. And they had to revise their findings very recently in 2010, when more and more tools became available for evaluating patients and their appropriateness for dialysis. So one of the tools that influenced the revision in 2010 was published in 2009 in Nephrology, Dialysis, and Transplantation. And this group took about almost 4,000 patients, aged 75 and over, who started dialysis between the years that you see there. They got their information from the RAIN registry and used various statistical processes to analyze it. And what they came up with was a point system score of outcome risk for 75-year-old patients starting dialysis. And you can see they're very familiar sort of outcome predictors: weight, diabetic status, heart failure, peripheral vascular disease, cardiac arrhythmias, active malignancy, behavioral disorders, being totally dependent on others for transfer between beds and chairs and wheelchairs, or if the dialysis in these 75-year-old patients were urgent, acute, or unplanned. And you can see you would get various number of points based on whatever the outcomes were. And to put this tool together, the 6-month mortality of a 75-year-old starting dialysis was about 19%. So after only 6 months on dialysis, 20% of 75-year-olds will have died. Age doesn't seem to be a factor, and the mean point score of these 4,000 patients was 2. But the mortality rates were definitely significantly associated with the number of points they scored. So an 8% mortality if they were basically fit and healthy with no points, going up to a 70% mortality rate if they accumulated 9 points or more. And you can see it wouldn't take very much to accumulate 9 points if you needed someone to help you from the bed to your chair. If you were also diabetic and you were slightly underweight, you'd get to 9 points pretty quickly. And those patients over the age of 75 would, as I said, have a 70% mortality rate with those existing problems. And then if patients died after withdrawal from dialysis, about 17% of them did, none of the patients who were very healthy withdrew from dialysis in that time frame. But if you had 7 points or higher, a 15% withdrawal rate and death thereafter. So these are the kind of outcomes of elderly patients starting dialysis that began to influence how we looked at them. And here came the revised dialysis clinical practice guidelines that were published only in 2010. Along with their publication have become a lot of tools to help you calculate these various risk factors that we've described already. And of course, like almost everything else nowadays, there is an app for that. You can get the Predictors app from the iTunes store or the Android app store, and it has various predictors that you can use to come up with similar scores. So there's CKD calculator scores, the surprise question score, which has a lot of relevance, and one of my colleagues will almost certainly be talking about tomorrow. The question that we ask nephrologists: would you be surprised if this patient died within the next 6 months? And if the answer to that question is no, then their outcomes are going to be very bad. It seems that nephrologists are usually pretty good at predicting when patients will survive. So if the nephrologist is answering no to the question, would you be surprised if this patient died, it's a big red flag. So lots of calculators are available to come up with these new scores that you want to assimilate. And then based on the revision, some recommendations were made. These recommendations centered first around establishing a shared decision-making relationship with your patient, developing a relationship for shared decision-making, fully informing your patient about end-stage renal failure, about their diagnosis, their prognosis, and various treatment options, including conservative therapy, and giving them an estimate of prognosis specific to their overall condition, a realistic expectation of how long they may expect to live if they started dialysis. It also revolved recommendations around facilitating advanced care planning, and certainly Sarah Davison is going to be talking about that tomorrow. The recommendations also revolved around making a decision not to initiate or continue dialysis if it's appropriate. So Foregoing dialysis should be considered in patients who have decision-making capacity, but have decided themselves not to have dialysis. We shouldn't be forcing them into. If they've lost the ability to make decisions, but have previously said when they could that they didn't want it, we should be considering not starting. If they no longer have decision-making capacity and their legal agents or their guardians make the decision for them, or if they have irreversible, profound neurological impairment, the so-called vegetative state, none of these patients should be really considered for dialysis. And in the same role, those with medical conditions that preclude the technical process of dialysis, so if we can't physically dialyze them, either because they have to be sedated or tied up or lots of other problems, if they have a terminal illness where usually they don't expect to be living more than a few months. There are some exceptions to this, especially if patients need time to put their affairs in order for a few months. And those, here's the most important one with respect to what this conference is about. The recommendation that those with stage 5 CKD, older than age 75, who have 2 or more of the following would be a very poor prognosis criteria, should be considered not to start dialysis. And they include that surprise question that I mentioned already, a high comorbidity score that we've looked at the calculators for, a significantly impaired functional status with respect to their day-to-day living and their daily activities, severe chronic malnutrition as evidenced by an albumin less than 2.5 in American units. So there's the age bias again in these recommendations. Other recommendations around resolving conflicts that make decisions about dialysis difficult. A time-limited trial of dialysis is often something to consider, especially in the elderly, to allow them time to see what life on dialysis is really like, and then to establish a systematic process for conflict resolution if there's a disagreement between physicians and patients and their families about if and when they should start dialysis. Finally, many patients worry about being abandoned and who will look after them if they either choose not to have dialysis or withdrawal from it. So you want to approach that head on and reassure your patients that you will have patient-centered outcomes and continue to look after them even if they choose not to have dialysis or withdrawal from it. So those are the recommendations that came, and you can see how age has factored into it. So as I come to the end of my talk, I bring you back to the question that started in South Africa. Is dialysis wasted on the elderly? And I think to help answer that question, I would introduce you to South Africa's probably most famous, and in fact the oldest person ever put on dialysis in South Africa, who was Nelson Mandela. So hopefully that answers your question, is dialysis wasted on the old? I leave you with a thought from another one of my favorite literary things. Everything is all right in the end. If it's not all right, it's probably not the end. So thank you very much for your attention. I hope that was of some value. Thank you.
Queda abierto el foro para comentarios o alguna pregunta.
Doctor, muy interesante la plática. Creo que en México, en nuestra actuación clínica, hemos empezado a ver pacientes que requieren alguna terapia renal sustitutiva, llámese diálisis o hemodiálisis, y que nos estamos encontrando más pacientes de 70 o más años, y que efectivamente tenemos nosotros la premisa de ofrecerles un tratamiento adecuado, de calidad y apegado a los lineamientos éticos que usted mencionó, y que es cierto que necesitamos valorar a cada paciente de manera individual para poder ofrecerle el tratamiento, a pesar de que algunos familiares mencionen o no quieran o no estén de acuerdo en el inicio de diálisis peritoneal o de hemodiálisis de su paciente de más de 80 años por todo el riesgo que ello conlleva. ¿Ustedes cómo han manejado esto?
The conflict you're talking about between patients and their families? Yeah, it's often the case that we have, it's usually the case that the family would want to continue with active therapy and the patient is saying no. I would say that's the most common. It's easy from a point of view to say we take the patient's wishes as paramount, and then usually comes in the art of medicine to try to bring families on board with those decisions. If it's the other way around, where the patient wants it and the family don't, then it's still the patient who is the first line of decision making. I think in the very elderly, we've had a bit more success in acquainting them with the statistics in a more layperson way of saying, if you're 85 or approaching 90, and I have many patients in that age range, I can show them data, or I can tell them about data that says, I can probably keep you alive for a similar length of time with perhaps an equivalent quality of life than if I put you on dialysis. In other words, putting a 90-year-old on dialysis may not guarantee him any more time than conservatively managing them. Those patients who have slowly declined over many years may live many years without dialysis, and that's what I try to reassure them of.
Muchas gracias por su conferencia. Yo quisiera preguntarle si tiene datos acerca del punto de vista del paciente que en un inicio se niega al tratamiento y por fuentes externas, familiares o personas que lo rodean, lo convencen, y a los 6 meses, ¿qué piensa el mismo paciente que tal vez se negó en un inicio? O cómo es la aceptación de la muerte de estos pacientes o que se están enfrentando a la muerte, aunque la tasa de mortalidad sea tan baja, ¿no? O sea, como médicos lo sabemos, pero el paciente cómo reacciona, cómo va la evolución del pensamiento ante la muerte inminente.
I've got lots of different experiences there. I find I kind of work with the old adage that it's always easier not to start dialysis than it is to withdraw. I found that over the years, if you can have a fruitful and heartfelt conversation with patients and their families, and everybody comes to the decision not to start, that's better and easier than letting them go on dialysis only to have a few months down the road it become obvious that we shouldn't have started and now we have to try to withdraw. Contrary to that, however, I've also found over the years great value in the predetermined trial of dialysis. So if patients are ambivalent or patients and their family are not on the same page, then sitting down and having a prescribed trial of dialysis, we usually consider about 3 months. And everyone knows it's a trial, and then you reassess at the end of 3 months and allow patients to say, now that you've been on it for this length of time, what do you think? Is this something you want to continue? The trouble comes if you don't set that end point. You say you put patients on dialysis and then no one ever talks to them again about whether they want to continue. You had the hard talk when they started and you think, well, that's done, we got them on, and now somebody else takes them over on a different dialysis unit, or they move to a different place and nobody ever talks to them about it again. But the predetermined trial can be very beneficial in those kinds of situations.
Gracias, Steve, por tu magnífica presentación. En países como el nuestro, aparte de los factores que acabas de señalar, existe el factor de que el acceso a diálisis no es universal por cuestiones de tipo económico. Y muchas veces esto es el motivo por el cual el paciente o su familia decide no empezar una terapia, en este caso, de diálisis. Por lo general, la conducta que se sigue en estos casos es que se lo lleven a su casa a morir sin ningún tipo de apoyo adicional. En una situación similar, por ejemplo, en Canadá, donde el paciente, ya no sea por cuestiones de tipo económico, pero por cualquier otro tipo, que rehúsa iniciar diálisis, ¿qué Posterior es el que le da el médico el médico o el equipo médico a este paciente.
It's a great question. I start off with your first point. It's an unfortunate reality in the world that many countries are not as fortunate as others and to be able to finance every aspect of medical care. And I'm the first one to accept that in Canada we are extremely lucky. And I think I can honestly say in Canada no one gets refused dialysis based on financial need. And we're not so fortunate in other parts of the world. But if patients do decide to not have dialysis or withdraw from it, that's the most important one of the recommendations about palliative care and support thereafter. I don't want to steal Dr. Davison's thunder because I know she's going to be talking about this in depth tomorrow, but we have great programs in place just for that. We have palliative care programs in Edmonton that start even before a patient has ever made a decision to withdraw from dialysis, to let them know we're already supportive of their ongoing needs, especially pain management, those kind of issues. And then once they stop dialysis, for whatever reason, the same teams that were looking after them on dialysis, with perhaps the obvious exception of the dialysis nurses, continue to look after them. I often continue to look after patients in my clinic after they've stopped dialysis. I offer them admission for terminal care, or we facilitate home care for their terminal time as well. And many patients wish to go home for terminal care as well. But we have an amazing home care facility for palliative care as well. If a given country is unable to finance the very expensive end of that equation, perhaps resources could be liberated to fund the other end. And maybe the decision to not have dialysis and have home care for terminal care could be better funded. Thank you very much indeed.
Agradecemos al doctor su ponencia, muy interesante. La verdad es que tiene algunos datos que nos pueden ser de bastante utilidad aquí en México. Diálisis en octogenarios y nonagenarios en el USSR. Adelante.
Good afternoon, and I would like to also thank the organisers for the very kind invitation to be here, not least because it's been the coldest weather probably in history in Minneapolis, so thank you one and all. Now, I'm going to go heavy on the data side, so I apologise, and I understand it's late in the day, but I'm going to present you data that has not been published, but that we're hoping to submit for publication soon. So for this talk, I'm going to use United States Renal Data System, USRDS, standard analytical files. And I'm going to start fairly gently with a description of incident and prevalent numbers for patients on dialysis and transplant over the age of 80. And then I'm going to do a talk about standardized incidence ratios, which is a way to try and find out if changes in these counts are because the population has changed. In other words, the natural history of these diseases or how we take patients onto dialysis hasn't changed. And in a fairly standard method, then I'll do exactly the same analysis, but look at the big causes of kidney disease that we're familiar with, like diabetes and hypertension in the US. And then I'll diverge a little bit into some of the more specific causes, because that's very interesting. And then I'll get onto a technical issue that might be of relevance, which is in the US and other countries, people are initiating dialysis at GFR levels that we would never have considered even 10, 15 years ago. And then I'll finish by describing the characteristics of people who are 80 to 90 when they start dialysis and those who are even older. So the first slide is very straightforward. So these are counts of incident cases of end-stage renal disease treated with renal replacement therapy in the US. This would be virtually 100% dialysis. So you can see a kind of a curvy linear shape. And just to orient you, the population of the US in this time period goes from about 250 to 310 million. So you can see the rate of change in the incident dialysis population over 8 far exceeds that in the general population. But having said that, the numbers are actually low relative to the population size, especially in 1990. So next one is, how about prevalent? So these are people who are on treatment on 1st of January of each of these years. And you can see the same type of pattern. So there's a linear increase in the prevalence of patients over 80 in the US. And you can see the magic number of 50,000 has been passed as of 2010. So in other words, there are 50,000 people on dialysis on January 1st in the US of 2010. So that's, you know, a substantial number. That's getting up to 10% of the total end-stage renal population prevalent-wise is on dialysis in the US on those days. Now, if you take another look, these are the older segments. These are prevalent cases of ESRD on the 1st of January of these years. You can see that the shape is no longer linear. It's actually some geometric shape that I've forgotten since my high school mathematics days, but I would say that's parabolic. So you can see that the rate of increase in prevalence is actually accelerating in recent years. So, moving on. Now the next bit is to describe a little bit about what we're doing with standardized incidence ratios. These are very easy, but a small bit of explanation would be helpful. So for most of the remaining slides, I'm going to limit the talk to the time period from 2001 to 2010. So that's one calendar decade. And for all these analyses, we're picking the first 2 years as our comparison point. So the reference here is the 2-year period, 2001 to 2002. So within the US general population, we calculate rates of ESRD requiring dialysis for multiple age, sex and race combinations. And then, having done that, we apply these rates from 2001, 2002 to subsequent populations. And from this, we can calculate an expected number of cases for these 2-year periods after 2001. So, simply put, the standardized incidence ratio is the expected number of cases based on findings in 2000, 2001 versus the actual number of cases. And if this standardized incidence ratio is above 1, it implies that the increase in the dialysis population can't be explained by changing demographics, most notably aging of the general population. So, now, here is the very first slide. So, these are incidence rates in people above 80 in the US. And this is for the first 2-year period I spoke about. This is 2001, 2002. And the reasons I'm putting this up are manifold, but predominantly to show you the baseline number, because it's useful to know where you're starting from. So you can see the most important The most important statistic here is that the incidence rate in the US is 1,300 per million population of people over 80. So roughly speaking, 1 in 1,000 adults over the age of 80 in 2001, 2002 would go on dialysis therapy, de novo. And you can see that as you go to age, then that the incidence rate actually declines with increasing age. which goes against the biology of chronic kidney disease, as we know that GFR levels tend to decline with age. You can see that there's a vast predominance of male incident cases in this year, and then you can see there's quite a divergence in terms of race ethnicity. So African Americans have by far the commonest incidence rates, roughly 3 times those of whites of equivalent age. And then you can see people with Hispanic Latino ethnicity also have high rates, but not quite as high as seen in African Americans. So this is the baseline. Now, these are the standardized incidence ratios. So within each one of these clusters, I'm looking at the first 2-year period, the second, the third, the fourth, the fifth. And this is looking at all comers here. So you can see if you examine this, there's quite a large rise between 2003 and 4 following 2001 and 2. And then around 2005 and 6, the incidence ratio seems to plateau. And if anything, as you go out towards 2009-10, it's actually declined. So it's commonly held that the incidence of end-stage renal disease among older people in the US is continuously rising. That's not the case, actually. If anything, it's plateaued overall. Now, if you move into the next cluster, I've somewhat optimistically grouped these ages into 4 age groups. So look, I've got the 80 to 85, 85 to 90, 90 to 95, 95 plus. Now, the numbers are getting small, certainly out here. But just to show you qualitatively, there is quite a difference in the incidence rates by age group. So the 80 to 84, which is the dominant group numerically, is much like the parent population here. But you can see as you move along the age groups, the qualitative feel of these numbers changes. And you certainly get the sense that as you move out into the age groups, 90, 95 plus, this incidence over time is actually not leveling off. So to summarize that, the younger old people, which is a strange term, maybe there's a plateau effect and are declining. You're not seeing this in the people who are 1990 and above. Now, if you move out here, then it's worth noting that there is a fairly significant difference in the shape of these clusters by sex. So among males, the climbs from 2000 2001 are more steep, but there is a plateau effect. And then you're also seeing that there is a quite marked difference by race and ethnicity over here. So for white Americans, for example, the jumps are larger and the plateaus maybe are earlier. So that's for overall. Now, among US dialysis patients, ESRD is the most commonly cited cause from diabetes. So how does this comparison look if you take it for just diabetic nephropathy? So again, I'm showing you the baseline incidence rates in 2001, 2002. And much of this will be of no surprise to you, but as before, you can see that there's a very profound age step function here. So their incidence declines markedly with age band. There's a male predominance, and then there's a very marked racial ethnicity difference. Unlike the overall pattern, however, African Americans and Hispanic Latino Americans, they seem to have similar incidence rates in this year. So what happens in terms of the standardized incidence ratios? So if we move to the first cluster here, for diabetes as a cause of end-stage renal disease, there's a fairly obvious step function until you get to 2007 and 8. And then after that, there may be a plateau. And as before then, if you want to go through all these clusters, you can see that there are marked differences by age group, by sex, and by race ethnicity. And just to pick one of these out, if you take, for example, the group that is 80 to 84, the standardized incidence ratio trajectory is markedly different from older people as out here. And then as you get up to age 95 plus, I think the numbers are too small to be definitive. And then finally, among the big causes, how about hypertension? Hypertension turns out to be the most commonly attributed cause in this population. Unlike previous slides, the step function for age isn't as apparent until you get to 90. Again, there's a marked predominance of males, and then for race ethnicity, African American stands out as being far above all others. So how do the standardized incidence ratios evolve over time in this hypertension as cause of ESRD? So here is the overall cluster. This is very different to what I showed you from diabetes, in that there seems to be an increase in 2003 and 4, and by and large there's a plateau after that. So in other words, there seemed to be an increase, doesn't seem to be increasing anymore. Potentially it's actually declining. And then I won't go through every individual set of clusters, but you can see that, as for other slides I showed you, there are marked differences by age band, there are marked differences by sex, and then there are differences which are less marked for race and ethnicity. So that's difficult, but to summarize that, there seemed to be great enthusiasm for dialyzing older people beginning in the start of the decade, and that seemed to level off. So now, so moving forward, in many countries, and somewhat based on recommendations, like as in KDIGO and KDOKI recommendations, people are initiating dialysis at ever higher GFR levels. So when I was training, 10 was a number that you would say consider for GFR seriously, and 15 was a number that you'd be starting to think about it. But times are changing, so a natural question is, well, if we were comparing people who started ESRD at a certain GFR threshold, in other words, below these numbers, how would the incidence comparison look? So these are standardized incidence ratios for people over 80. And as before, you can see that in the first 2 years it went up in the US, went up again in the 2005, 2006, and then there was a plateau of the incidence ratio and a apparent diminution, statistically significant but not large. Now, if you do the same type of analysis but limit the comparison to people who had a GFR with less than 50 with the CKD-EPI equation, the pattern looks slightly different. So you get a pattern in which, as before, things start to accelerate up to 2006, but there's a stepwise decline after 2006. And finally, if you do the comparison on a number which I would be very familiar with, which is 10 as your threshold for initiating dialysis, maintenance dialysis, you find that there's actually a stepwise decline in the incidence. So this suggests that you need to keep GFR levels at which the population initiates dialysis into account when you're looking at incidence rates. So unfortunately, this really clouds the issue when you're starting to look at temporal trends. So now, traditionally the US RDS groups cause of renal failure into 6 or 7 big groups. So there's diabetes and hypertension, cystic disease, glomerulonephritis, etc. Now, I think most people in the room would know that rapidly progressive glomerulonephritis from Wegener's isn't quite the same as minimal change disease, but in this big category system, they're treated as being the same. So in the enrollment form in the States, people have to tick one of 82 more specific causes. So for purposes of interest, I thought it would be useful to see, well, if I look at a more specific cause of renal disease, what comes up. So here I've limited the analysis to diseases that turn up in more than 0.5% of the total diseases. So they're not incredibly rare. And then these are ones that turn out to be statistically significant when I compare to the last 2 years of follow-up with 2001, 2002. So this is a very nice summary. So the winner in this analysis is acute tubular necrosis. So in a 10-year period, the standardized incidence ratio of ESRD attributed to acute tuberous necrosis more than doubled. And then somewhat surprising, you find that the diabetes type 1 is the second most common in terms of rate of increase. Not too surprising, diabetes type 2 is also increasing. And then the ones that have decreased are shown in blue, so the entity of glomerulonephritis of unknown histology, whatever that is, that declined. Chronic interstitial nephritis declined. And probably because we're doing less angiograms in the States based on randomized trial evidence, the diagnosis of renal artery stenosis and renal embolic disease also declined. Okay, so the last part of the talk is just to describe the characteristics of incidence patients. And I'm doing this by era and by age. So just to orient you, the set of columns to the right is the more recent era. So this is 2006, 2010. And then these are people between 80 and 90. And these are people who are 90 or above. So you can see pretty easily here that the total number increased in both. So the number of 90 plus year olds increased from nearly 5,000 to 6.2 thousand in the second era. So if I start looking at these now, here is the exact same type of comparison within various subgroups. So the first big characteristic I'm looking at is racial characteristics. So you can see that among the people under 90, the predominant race is white, and that didn't change much over time. And then you can see that in people over 90, the proportion that are labeled as white actually increased, so here to here. Now, if you go for ethnicity, over here is people who are labeled as Hispanic or Latino in the USRDS. So in the earlier era, the proportions were similar in people under 90 and in people over 90. And then if you roll on 5 more years, you can see that there's been a change. So the people, there's been a slight increase in the proportion labeled as Hispanic Latino in 80 to 90. And then there's been a decrease in those over 90. So that's been a change. And then moving on to sex. If you look at the earlier era, the proportion labeled as female, presumably female, was higher in the older subgroup in the earlier era. And then in the next era, these have actually changed. So, for example, in people over 90, there are more and more males going on to therapy relative to what they were before. So it's become more of a male disease as you get older. Now, causes of ESRD, this is also worth looking at. So, for summary, the commonest attributed cause of these big group causation is hypertension. And if you take people 80 to 90 in the earlier group versus older, you can see that hypertension was more commonly attributed in the 90 plus year olds, and those trends have stayed common over time. Now you get a slightly different story for diabetes. So diabetes is being more commonly attributed as cause of ESRD in both population groups, whether it's 80 to 90 or 90 and above. Now, next thing then is I'm trying to get a sense of their comorbid illness burden. Now, this is a registry study, so it's based on somebody ticking a box, so things like comorbidity you really have to be a small bit skeptical about when you're in a registry study. But nevertheless, it's quite interesting all the same. So in the earlier era, people who were over 90 actually had less atherosclerotic heart disease than the slightly younger population. And then these trends accelerated as we moved through the decade. And then we saw for peripheral vascular disease the same type of pattern for less comorbid illness in the older group. And then the prevalence over time, or the percentage, was more or less the same. So this would tend to argue that there are selection factors that we can't really measure, but these are probably playing into the decision to start these patients on dialysis, which is totally expected. Now, another issue that the previous speaker touched on was this issue of immobility. So immobility here is defined as troubles with ambulation or with transferring. So no surprise if you look at the earlier era, the people who started dialysis over 90 years of age, even though they seem to have less cardiovascular disease, they seem to be more immobile, so that's here. And then over the decade, there was fairly obvious increase in the prevalence of immobility among people starting dialysis in the US. So that's a kind of a funny pattern that the comorbidity seems to be declining, but functional problems seem to be on the increase. Now, mode of therapy, well, in the US this would be no surprise, but it's virtually not 100%, but close to 100% are starting on hemodialysis. So this is 3-point-something% in the earlier era for the younger segment, and then this declines even further. And then in both segments, as you get beyond 2005, the use of peritoneal dialysis declines. Now, just some clinical characteristics then. This is the same type of analysis looking at the GFR story. So I already implied to you that the GFR pattern has changed quite markedly in the US, so I'm showing you that again. So over time, the proportion of people starting with a GFR over 15, it increased at an increase in both segments, both those under 90 and above 90. And then here's an interesting one which tells you something about the US. I think the proportion that had a body mass index over 30 increased in both segments. And then for biochemical characteristics, probably not too surprisingly, the proportions with albumin less than 3.5 grams per deciliter were slightly higher if you were over 90. And then the hemoglobin values were identical, so no change over time. Now, the next slide is a slightly different analysis. The USRDS didn't collect data on nephrology contact and on hemodialysis access at initiation of dialysis until 2005, and it was only routine in 2006. So this analysis is just it's restricted to people who were over 80 and started dialysis in after 2005. So probably the first one is to look at is nephrology care for over 1 year prior to initiation on dialysis. So you can see that among the people under 90, maybe 25% of the population has been with a nephrologist for a year or more. And then as you get to the older population, this gets closer to 20%. So this is quite disappointing, especially with such a difficult decision to make as initiation dialysis. And then among the hemodialysis population, this kind of reflects what goes on in the US anyway, but the proportion that start hemodialysis with a catheter is extremely high. So it's over 80% for people under 90, and it's approaching 90% for people who are 90 or more. And then if you're interested in the fistula side, it's conversely very disappointing. So maybe 12-13% start with a fistula, and as you get into the 90-plus-year-old group, possibly for technical reasons, but for many other reasons, the proportion is less than 1 in 10. So that's quite a lot of information, but here are my conclusions and highlights. So the first thing I showed you was that the incidence of ESRD treated with RRT, that has climbed rapidly in the US among people who are 80 or more. I showed you a similar story for prevalence. Then I tried to convince you that this acceleration in disease burden is as marked, if not more so, on a relative basis in the 90-year-olds. There are fairly obvious differences in terms of things like age, sex and race, but you have to bear in mind where the baseline level begins when you're looking at relative growth. I tried to convince you that most of the growth has occurred with diabetes and is somewhat less so with hypertension. I've tried to convince you that quite a lot of this growth is because we are dialysing patients at later GFR, higher GFR levels. Poor functional status, and I'm sure we underestimate this in the registry, that's more apparent. No surprise, hemodialysis in the US is the dominant mode of treatment. And then the state of the patients in terms of nephrology care is poor, and you could imply from that that planned transition to dialysis is the exception rather than the rule. So thank you very much.
Se abre el foro para alguna pregunta o comentario. Me gustaría que comentara, doctor, si es que hay algún dato acerca de el abandono de las terapias de diálisis en estos pacientes y si es posible nos diga la causa.
Could you repeat it? I didn't turn it on. Sorry.
Bien, si es posible que nos diga algunos datos acerca del abandono de los tratamientos de diálisis en este grupo de pacientes y también si es que tienen en cuenta alguna de las causas que ellos refieren.
Yeah, I'm going to present that tomorrow, but death as a cause of withdrawal is over 10%. We can imply withdrawal only through loss of follow-up. It's probably, I'm thinking 30% plus. I don't want to give you all the highlights, but the average survival gets up to about 9 months in this population. So yes, there is a lot of withdrawal.
Adelante.
Sin duda hay mejores recursos para ofrecer ya a los pacientes ancianos más opciones, más seguras, más refinadas. Pero ¿usted cree que, por ejemplo, en Canadá también se está dando o se ha dado algún cambio de mentalidad en los médicos para ofrecer este tipo de terapias? Porque muchas veces nos sentimos un poco cohibidos en ofrecerlas por la poca experiencia y la incertidumbre a veces de no tener el suficiente número de casos para hacerlo.
Yeah, for sure. It's the linear increase over time is somewhat a function of the money that people can make from dialysing patients. But it's very interesting that the incidence ratio in the 80 to 84-year-old is dropping, whereas the incidence ratio in the older people is actually going up. And I think people have more experience with the younger segment, and they have an idea of who they can treat conservatively and who they can't. But in the very old people, they are not as familiar. And in the States, the default, I would say, I'm actually Irish, by the way, and I trained in Canada and I trained in England, many different systems. The default in the States is to dialyse first and ask questions and have discussions afterwards. And some of that is the way that we're getting the patients so late. But I think there are changes. The flattening of the incidence ratio is very telling.
Adelante, doctor García.
Gracias, Robert. Muy interesante presentación. El incremento en la prevalencia en forma desproporcionada a la incidencia es un reflejo de una mejor sobrevida. Hace algunos años existía la observación de que la sobrevida de los pacientes en general en Estados Unidos era más mala que en otros países como Japón. ¿Eso ya se ha corregido o nos pudieras comentar sobre ese punto?
You are correct, and in international comparisons of the general population, the US doesn't do well, and it isn't increasing in the league tables. It's I don't know, it's in the 20s for expected longevity the last time I looked. The mortality in the dialysis population, the survival is increasing more quickly than it is in the general population. That's very clear from, you know, what we're seeing. We haven't done that in the older population, but that would be a very relevant analysis we could do to see your first observation is very on the ball, because the prevalence is being totally driven by the survival. So if you you see the prevalence going like this. If you plot survival on this axis and incidence on this, until maybe 2005, incidence was driving the prevalent size, and then after that, it was actually being driven by survival. So in economic terms, you become a victim of your own success. The patients survive longer, but you have more of them. And as I'll show you, they're very, very expensive to care for. So, very good point.
Muy bien, continuando con el programa, vamos a dar paso a un receso de 30 minutos. Bueno, pues continuando con el programa y dando fin a al simposio número 3 de las terapias de reemplazo renal en la tercera edad. Con la última plática tenemos a la doctora Xochitl Guerrero Durán. Ella es egresada del Hospital Civil de Guadalajara y actualmente es encargada de una clínica de hemodiálisis de pacientes subrogados y pacientes privados del Instituto Mexicano del Seguro Social. Su plática va enfocada a algunos datos que arrojó estas unidades de algunos pacientes que pueden ser comparativas a los análisis mostrados anteriormente en pláticas previas. El título de la clase es Hemodiálisis en la tercera edad en México. Démosle la bienvenida con un fuerte aplauso, por favor.
Buenas tardes, muchas gracias a todos por su asistencia. Bueno, mi tema el día de hoy es hemodiálisis en el adulto mayor en México. La enfermedad renal crónica en el adulto mayor afecta cada vez más a los adultos mayores, de manera tal que la incidencia en la población general es básicamente el 8%, y cuando hablamos de pacientes por arriba de 65 años, esta se incrementa en un 30% y países han reportado una incidencia hasta del 50%. Esta población es la de mayor incidencia, es la que tiene un mayor aumento en su incidencia, perdón. La situación mundial actual, bueno, en España, en el estudio PRIS, se dio una prevalencia de 23.6%, Canadá una prevalencia de 35.7%, Estados Unidos una prevalencia del 23 al 25%, y en México lamentablemente no contamos con una base que nos permita dar un consenso preciso de nuestra prevalencia actual. Bueno, cada vez más se integran a pacientes con enfermedad renal crónica, adultos mayores, a terapias de reemplazo renal en México, y se prevé que en los próximos años probablemente la hemodiálisis sea más popular que la diálisis peritoneal. Actualmente la proporción de hemodiálisis y diálisis peritoneal ha cambiado. Previamente era de un 80 versus un 20%, actualmente es de un 40 versus un 55-60%. La población mexicana también ha aumentado su esperanza de vida. Actualmente tenemos una esperanza de vida de 82 años y se estima que para el 2050 la pirámide se invertirá de manera total y que los adultos mayores se duplicarán en número. El 95% de los adultos mayores que inician terapias de reemplazo renal lo hacen en la modalidad de hemodiálisis. En nuestro país no hay un consenso actual que nos permita hablar de que esta terapia es la más usada en nuestros pacientes. La edad promedio que inician terapia de reemplazo renal es 62 años, con una máxima de 90. En México también se está observando una tendencia cada vez mayor a iniciar a los pacientes en terapia de reemplazo renal. Según los reportes del USDRS, la tasa de inicio de terapia de reemplazo renal en mayores de 80 años se incrementó en un 57% del año 1996 al 2003, pasando de 7.054 pacientes a 13.577. Los factores asociados al incremento de la enfermedad renal crónica terminal en los adultos mayores están obviamente muy relacionados con el aumento con la edad en la prevalencia de las dos principales enfermedades que causan esta enfermedad, que es la diabetes mellitus y la hipertensión arterial. Un aumento en la esperanza de vida de los mexicanos, que actualmente es de 82 años, el envejecimiento renal natural y obviamente la mayor disposición de nosotros los médicos nefrólogos para dar un tratamiento óptimo en el adulto mayor. El envejecimiento renal, como ya lo comentaron muchos de los ponentes previos, consiste en una disminución en lo que es el flujo sanguíneo renal, que si en etapas tempranas de la vida es de 1.200 mililitros minuto, cuando llegamos a la cuarta década de la vida esta se reduce hasta 650, para que cuando lleguemos a la sexta década de la vida, esta tiene una disminución de 250 mililitros minuto, lo que ocasiona un aumento de las resistencias periféricas con una caída básica de lo que es la tasa de filtrado glomerular. Obviamente esto conlleva a que haya una menor excreción urinaria de creatinina, que si en un adulto promedio lo normal es de 20 a 25, cuando llegamos a la cuarta década de la vida esta cae hasta 10 y cuando pasamos la sexta década de la vida puede caer hasta 5. Y obviamente esto produce cambios a nivel renal, que básicamente son una hipertrofia glomerular con un adelgazamiento de la membrana basal que ocasiona un aumento en la incidencia de lo que es la microalbuminuria, independientemente de que estos pacientes presenten o no agregadas comorbilidades como la diabetes y la hipertensión, pero estos pacientes tienen una mayor prevalencia de microalbuminuria. Hablando del cálculo de la tasa de filtrado glomerular en el adulto mayor, la creatinina quizás no sea el parámetro más fiable para calcular en estos pacientes la función renal, debido a que los adultos mayores tienden a tener una disminución de la masa muscular con el envejecimiento. Y como todos sabemos, la creatinina se modifica con respecto a la masa muscular. Básicamente en este ejemplo se nota que una creatinina sérica en un joven de 22 años, en un adulto de 58 y en un paciente de la tercera edad de 80 años, con la misma fórmula para calcular la tasa de filtrado glomerular hay una variación muy importante. Las fórmulas de Crocroft-Gold y de MDRD de 4 y 6 elementos tienden a sobreestimar la tasa de filtrado glomerular, por lo cual la más precisa de estas es lo que se ve en la parte de arriba, marcado en verde, que es calculado por CKD-EPI. Y quizás si quisiéramos ser un poco más precisos, podríamos añadir cistatina C, que no se modifica con la masa muscular, y dar un poco más de precisión a esta fórmula. Sin embargo, hasta el momento no existe una fórmula precisa para calcular la tasa de filtrado glomerular en el adulto mayor. El manejo de la enfermedad renal crónica en el adulto mayor debe de ser un enfoque global e individualizado, que no solamente tome en cuenta la edad del paciente, sino la actividad física que él desempeña, los factores psicológicos, el apoyo familiar, los factores psicosociales y obviamente la cantidad de comorbilidades con las que el paciente cuenta. Para, dependiendo de esta valoración global, poder determinar si el paciente es o no candidato a terapia de reemplazo renal. El inicio de la terapia de reemplazo renal, como ya se comentó, no se determina dependiendo de la edad del paciente, sino que básicamente se valora por la presencia o no de síndromes geriátricos, siendo quizás el más importante de todos el síndrome de fragilidad del anciano, asociado obviamente esto a la esperanza a largo plazo de vida del paciente y al efecto del inicio de la terapia de reemplazo renal en la calidad de vida del paciente. Hablando del síndrome de fragilidad, en los pacientes por arriba de 65 años que tienen una tasa de filtrado glomerular por debajo de 40%, está presente hasta en el 80% de ellos y aumenta el riesgo de mortalidad hasta 2.5 veces más y el riesgo de hospitalización es 1.5 veces más. Hablando de lo que es la terapia, el inicio de la terapia de reemplazo renal para valorar si es prudente o no iniciarla en un paciente, podemos hacer un screening que se realizó en la población francesa, que son quizás la población que envejece más y que tienen un acceso viable a la salud. Este screening valora factores de riesgo para valorar la sobrevida a 6 meses posterior al inicio de la terapia de reemplazo renal, hablando de los factores de riesgo más importantes como un índice de masa corporal bajo, por debajo de 18, y las comorbilidades como enfermedad vascular periférica e insuficiencia cardíaca, y a la diabetes mellitus solamente le otorgan un punto. Cuando los pacientes tienen un puntaje mayor a 9 puntos, se habla de una sobrevida de una mortalidad mayor al 70% a los 6 meses, mientras que si el puntaje es 0, la mortalidad a los 6 meses es únicamente del 8%. Esto sería un parámetro viable para valorar en nuestros pacientes y valorar si en realidad es prudente o no ofrecer terapias de reemplazo renal. Hablando del tratamiento conservador en adultos mayores, si estamos a favor o en contra, bueno, es algo que es dependiente de cada nefrólogo, dependiendo de la valoración individual que hizo cada uno de nosotros, pero hablando de lo que es el manejo conservador, bueno, requiere en sí de un manejo multidisciplinario por el médico nefrólogo, por el geriatra, probablemente tratamiento por clínica del dolor. Y bueno, esta demostró en un estudio que se hizo en donde se les dio este tratamiento a 155 pacientes mayores de 75 años que tenían múltiples comorbilidades. Se demostró que la sobrevida era mayor en los pacientes que recibían terapia de reemplazo renal de 37 meses versus 13 meses de los que recibieron manejo conservador, alcanzando una P significativa de 0.001. Sin embargo, los pacientes se hospitalizaban mucho menos y tenían mejor calidad de vida cuando se les daba un manejo conservador, y el 71% de estos pacientes fallecieron en casa. Bueno, hablando de estudios que se han realizado, este estudio que valoró la funcionalidad de los pacientes adultos mayores antes y después del inicio de diálisis, es un estudio que se realizó en 3.702 pacientes, en el que las edades promedio fueron de 73.4 años. La gran mayoría de los pacientes, el 60%, eran mujeres y bueno, tenían múltiples comorbilidades. En el 68% de los casos fue diabetes, seguido por insuficiencia cardíaca en el 66%. La gran mayoría de los pacientes iniciaron terapia de reemplazo renal con hemodiálisis. En este estudio se valoró de acuerdo al score MDS-ADL, en el que se tomaba en cuenta una disminución significativa por debajo de 2 puntos del valor inicial. Se tomó como corte el mes 0, en donde el score fue de 12 puntos. Se valoró a los 3, a los 6, a los 9 y a los 12 meses posterior al inicio de la diálisis en enfermos con enfermedad renal crónica que vivían en casas de retiro o asilos. Se determinó que todos los pacientes tenían un deterioro funcional significativo con respecto al avance del tiempo en la diálisis peritoneal, en la hemodiálisis, y que esto alcanzaba hasta 16 puntos después del año de haber iniciado hemodiálisis. Cuando se observan estas gráficas, Cuando observamos estas gráficas, observamos que con respecto a que aumenta el tiempo en hemodiálisis, los pacientes mueren más, alcanzando la máxima a los 12 meses, que representa un 58% de mortalidad posterior al inicio de diálisis. Los pacientes tienen un deterioro estadísticamente significativo del estado funcional, y los pacientes que mantienen su estado funcional son sumamente pocos. Entonces existe una correlación directa entre disminución de la funcionalidad y aumento de la mortalidad después de haber iniciado hemodiálisis. Con respecto a la sobrevida de los pacientes con enfermedad renal en estadio 5 comparados con tratamiento conservador, esto es un estudio que se realizó en 800 pacientes. 689 se les dio tratamiento con diálisis y 155 únicamente recibieron tratamiento conservador. Es notable las diferencias en las características demográficas. Los pacientes que recibieron tratamiento conservador eran significativamente más viejos y tenían mayor número de comorbilidades. Cuando se hace el estudio comparativo sin tomar en cuenta la edad ni las comorbilidades, resulta que los pacientes tenían una mejor sobrevida si recibían terapia de reemplazo renal, 67 meses versus 21 de aquellos que recibían tratamiento conservador, alcanzando una P significativa. Pero cuando se hace el ajuste por edad y por comorbilidades, resulta que los parámetros cambian. Los pacientes que tienen edad mayor a 75 años y que tienen más de 2 comorbilidades tienen mejor sobrevida si únicamente reciben tratamiento médico conservador, menor número de hospitalizaciones y mejor calidad de vida, valorando con el estado funcional del paciente. Para valorar la sobrevida ajustada por sexo, edad y comorbilidades, el único punto notable en esto es que ser mujer es un factor independiente para que tengan una mejor sobrevida. Les va mucho mejor. Hablando ya de lo que es la terapia de reemplazo renal en adultos mayores, los resultados en México, como todos sabemos, en México no tenemos una base de datos que nos permita conocer de manera precisa cuántos pacientes de los que tenemos con enfermedad renal crónica tienen más de 65 años y mucho menos conocer cómo es la evolución de estos pacientes a través del tiempo. Bueno, este es un análisis de 7 centros de atención de hemodiálisis en la República Mexicana, del periodo de enero del 2010 a enero del 2014. 7 centros de hemodiálisis en 4 estados. La población general eran 1,418 pacientes. De estos tenían más de 60 años, 463 pacientes, y se les dio un seguimiento por 48 meses. Este estudio incluye pacientes tanto asegurados como no asegurados. Hablando de la proporción por género en la población general, la gran mayoría de los pacientes, el 64%, son pacientes de sexo masculino. La población de pacientes añosos, igualmente, el 67% son pacientes del sexo masculino. En la proporción por género sigue predominando creo que es lo mismo, perdón. Bueno, el 67% son hombres, hablando del adulto mayor. La causa de la enfermedad en los adultos mayores, la principal causa fue diabetes seguida de hipertensión. La tercera causa es desconocida. El tipo de seguro médico en la población general es básicamente aporte federal, seguido por un aporte estatal. En los pacientes mayores de 60 años, igualmente, el aporte federal es el mayor, representando el 60% de los casos. Los pacientes que estaban actualmente en hemodiálisis que tenían más de 60 años, únicamente el 32% habían estado previamente en diálisis peritoneal, mientras que el 68% nunca habían estado en diálisis peritoneal. La diálisis peritoneal previa, únicamente se dio en 110 casos. La proporción de pacientes en hemodiálisis sin antecedente de diálisis peritoneal fue de 311 pacientes, que representa la principal causa para no entrar a diálisis peritoneal fue un defecto de la pared abdominal, seguido por peritonitis. Y las causas de egreso de diálisis peritoneal, la principal fue peritonitis. El KTV promedio en nuestros pacientes fue siempre por arriba de 1.2, que son datos muy similares a los reportados en otros países. Y el porcentaje de pacientes con un KTV por arriba de 1.2 alcanzó el 60%. Nuestros pacientes, la gran mayoría, tenían fístulas arteriovenosas. La gran mayoría de los pacientes con diabetes mellitus tenían fístula. Cuando hacemos la división de acuerdo al tipo de seguridad social que tenía el paciente, se valora que los pacientes que tienen un aporte federal o que no tienen ningún aporte, o sea, los pacientes privados, tienen mayor cantidad de accesos vasculares temporales, comparados con los que sí tenían seguro médico. Las causas de egreso de la hemodiálisis, la principal causa fue la defunción en el 90% de los casos. Esto representa básicamente el 50% de las causas de egreso de lo que es la hemodiálisis, seguida por lo que es un cambio de establecimiento y cambio de residencia del paciente. Si vemos el trasplante, seguimos en pañales aún, pues únicamente el 3% de los casos se fueron por trasplante. Y la descontinuación de la hemodiálisis son aquellos pacientes que deciden retirarse de manera voluntaria de lo que es el tratamiento, que únicamente fue el 2% de los casos. Las causas de egreso de hemodiálisis por etiología, sigue siendo la principal causa, diabetes mellitus, seguida por hipertensión, y la pérdida de seguimiento también es un factor importante, sobre todo en los pacientes que no cuentan con seguridad social. El acceso vascular al momento de la defunción, la gran mayoría de los pacientes tenían un catéter Permacat en el 34%, seguido de una fístula arteriovenosa y bueno, un 3% de los pacientes estaban en proceso de maduración de una fístula. Lamentablemente de esto no contamos con un dato preciso para saber de estos pacientes cuántos no tuvieron una maduración adecuada del acceso vascular, como la fístula, que es algo sumamente común en el adulto mayor y que es la principal causa de que sea superior el número de accesos vasculares permanentes en estos pacientes por el daño endotelial que tienen este tipo de pacientes. La tasa de mortalidad, bueno, muy similar a la reportada en estudios de otros países, en donde el mayor pico se observa al primer año de haber iniciado la terapia de reemplazo renal. Y como conclusiones, un tercio de los pacientes en hemodiálisis son mayores a 60 años. Predomina que los pacientes con enfermedad renal crónica terminal en secundaria diabetes mellitus sean del sexo masculino. 6 de cada 10 pacientes cuentan con seguro federal. Solo un tercio de los pacientes en hemodiálisis cuenta con el antecedente de diálisis peritoneal previa. Y el nivel de hemoglobina, el KTB y el URR reportados en este estudio para los pacientes de más de 60 años son similares a los reportados en el resto de la población. La tasa de mortalidad también fue similar a la reportada en el resto de la población general en hemodiálisis. Sin embargo, obviamente se requieren de mayores estudios de tipo epidemiológico para valorar la situación real de los adultos mayores en hemodiálisis en nuestro país. Y pues obviamente valdría la pena aplicar encuestas de calidad de vida en esta población para estudiar si en realidad la terapia de reemplazo renal ofrece una mejor calidad de vida a estos pacientes y una mejor sobrevida. Y se requiere mejor investigación formal sobre la modalidad ideal de terapia de reemplazo renal para estos pacientes, tomando en cuenta las limitaciones por los síndromes geriátricos, el desgaste energético calórico, la calidad de vida, la esperanza de vida y obviamente las comorbilidades, que muchas veces son la principal causa por la cual no ofrecemos terapia de reemplazo renal, siendo obviamente la más frecuente la cardiovascular, que es una de las contraindicaciones para el inicio de hemodiálisis, que sería un punto a favor del inicio de diálisis peritoneal en estos pacientes. Bueno, pues es todo. Muchas gracias.
Gracias, doctora. ¿Alguna pregunta por parte del público? Adelante.
Sí, doctora, cuando dice terapia conservadora, ¿quiere decir nada más suspensión del tratamiento de reemplazo o implica algo más?
No, básicamente era suspensión o, bueno, no inicio de la terapia de reemplazo renal, pero seguía con un tratamiento médico indicado por el médico nefrólogo en conjunto con el geriatra y si había necesidad se valoraban por médicos de clínica del dolor y clínica del sueño.
¿Y hay alguna diferencia en estos pacientes en dejarlos en este tipo de tratamiento, por decirlo así, o darles opción ya a una terapia paliativa formal?
Yo supongo que es una manera alternativa de llamar a un tratamiento paliativo en estos pacientes. No viene en el estudio especificado como una diferencia como tal, pero básicamente si hablamos de tratamiento paliativo hablaríamos de eso, de dar un tratamiento médico conservador al paciente sin someterlo a algo más allá porque no vamos a prolongar la sobrevida del paciente y vamos a disminuir su calidad de vida.
Bueno, como sumatorio al comentario del manejo convencional, yo creo que es algo demasiado ambiguo y muy subjetivo decir, bueno, que es un tratamiento convencional, ¿no? o un tratamiento no invasivo, algunos otros lo han llamado. Pero definitivamente creo que tenemos un gran obstáculo cuando le ofrecemos a un paciente que únicamente va a recibir diálisis. Creo que hay un gran obstáculo el decirle que solamente es diálisis y nos olvidamos de todo lo que conlleva un tratamiento no invasivo, como por ejemplo las terapias paliativas, que bien lo dijo la doctora, los tratamientos con psicólogos, con el grupo de apoyo, con los cuidadores. Es decir, el paciente que está en diálisis debe tener todo lo demás que es conservador y no únicamente diálisis, pues, y difícilmente hacemos esa división de manera tajante siempre.
¿Qué tanto afecta los números que nos presentas el hecho de que estés hablando de una unidad que subroga pacientes del IMSS, que tú los catalogas como federales, entiendo. Porque finalmente no tienes el acceso a la población directa si no es los que te mandan, ¿sí? Y no siempre a las unidades que nos dedicamos a esto nos mandan a los pacientes jóvenes, más bien nos mandan siempre a los pacientes que tienen ciertas condiciones que las hacen desde ser candidatos para irse a este tipo de unidades hasta para manejar este tipo de situaciones. Entonces, ¿qué tanto los números enmascaran este tipo de situaciones que no pueden ser reales en términos de decir es realmente la población que está creciendo bajo este esquema, sino una condicionante de una forma de trabajo en una unidad de hemodiálisis?
Bueno, estoy totalmente de acuerdo con usted. Lamentablemente, como lo comenté al inicio, no existe en México una base que nos permita llegar a un consenso de cómo les va a los pacientes adultos mayores en hemodiálisis, porque no existe una base que nos diga eso en México. Entonces, lo que quisimos crear nosotros es para dar un sobreentendido de cómo es bueno, a grandes rasgos, cómo es que a la población que nosotros manejamos le va, que es básicamente lo mismo que se ha reportado en otros países. Lo que usted dice tiene mucha razón. La gran mayoría de los pacientes que recibimos en este tipo de hemodiálisis no son los mejores candidatos. Por lo general nos mandan a los pacientes con más comorbilidades, más añosos y con muchas otras cosas para no lidiar con ellos, pero bueno, es así, ¿no? Y la verdad yo creo que sí deja un sesgo bastante importante, pero creo que para hacer un primer paso es bastante bueno que lo empecemos a tomar en cuenta y de aquí empiecen a surgir más necesidad por investigar más allá de cómo nos va, porque somos un país que está en vías de desarrollo y que estamos llegando a donde están los países ya desarrollados y que estamos alcanzándolos en muchas cuestiones ya. Creo que nuestro crecimiento de enfermedad renal crónica está para que nosotros empecemos a dar pie a más investigación cada vez para saber cómo les va a nuestros pacientes. Gracias.
Gracias, Xochitl. Muy interesante y creo que el estudio, con sus limitaciones, obviamente no se puede generalizar por no ser una muestra representativa, pero sí nos da cierta idea de la situación de la diálisis en general en el paciente adulto mayor. En general, creo que si tuviéramos acceso universal a diálisis como sucede en el paciente del Seguro Social y del ISSSTE, lo que hemos observado efectivamente es de que existe una mayor proporción de pacientes mayores de 60 años, porque creo que en población abierta el sesgo es al revés, o sea, ya sea por limitaciones socioeconómicas, principalmente la tendencia es que un buen porcentaje de pacientes mayores de 60 años no ingresan al programa, pero sí ya tenemos cuando menos una referencia que el 30% de los pacientes en estos centros de referencia pues tienen una edad mayor de 60 años. También llama la atención de que a pesar de que son adultos mayores, que es donde en un momento dado se recomendaba que la mejor terapia era la diálisis peritoneal por los problemas de enfermedad cardiovascular de estos pacientes, vemos que aquí es a la inversa, la mayor parte están en hemodiálisis y un porcentaje menor está en diálisis peritoneal. Aquí la cuestión creo que sería importante ver ya resultados, es decir, aunque nos diste la tasa de mortalidad de una forma muy global, habría que desglosarla por modalidad también de tratamiento. Y también me llama mucho la atención el que ya la hemodiálisis dejó de ser, cuando menos en este grupo, una terapia de apoyo, una terapia de salvamento, como lo era antes, porque ya prácticamente creo que 6 de cada 10 pacientes que tienes en este programa entraron directamente a hemodiálisis sin diálisis peritoneal previa. Pues muy interesante, felicidades.
Gracias.
¿Alguna otra pregunta? Me sumo a lo que comenta el doctor García, muy interesante, sobre todo porque pues en México nos enfrentamos a una transición epidemiológica demasiado fuerte, que nuestro sistema de salud no tiene la capacidad ni de médicos ni económica para hacer frente a una enfermedad tan cara como es la enfermedad renal y que creo que los estudios como los que usted nos está presentando, doctora, sirven como pie para tomar decisiones. Las estadísticas que al fin y al cabo son pilar para toma de decisiones, esto debe de influir en la gente que toma las decisiones en salud. Y pues, si no hay más preguntas, los esperamos el día de mañana a las 9 para empezar el simposio. Por favor, puntuales. Muy amables. Gracias.
Gracias.